Welcome to the American College of Correctional Physicians, ACCP YouTube channel podcast, where we explore the exciting landscape of correctional healthcare with leading experts across the nation. I'm Dr. Susan Rashid, a family medicine physician, and it is a privilege to bring you conversations that illuminate the courage, strategy, and innovation required to deliver healthcare in the correctional setting. Today, I am joined by my esteemed co-host, Dr. Jeffrey Keller, the current president of ACCP. With decades of leadership in correctional healthcare, Dr. Keller continues to shape our profession's future through advocacy, education, and high standards of care. We are deeply honored to welcome our guest, Dr. Gregory Ladele, the newly appointed Chief Medical Officer of CFG, where he directs the daily healthcare delivery for thousands of patients across the state of New Jersey and New York. A proud native of Philadelphia, Pennsylvania, Dr. Ladele's leadership spans public and private health sectors with career-defining roles that have blended his clinical depth with administrative foresight. His work has ranged from primary care for underserved populations in Florida to executive roles in correctional medicine. Dr. Ladele's vision is guided by a personal mission to bridge healthcare disparities through evidence-based medicine, emotional intelligence, and cultural humility. He is a graduate of Morehouse College, earned his MBA from Tennessee State University, received his medical degree from the University of Medicine and Dentistry of New Jersey, and completed his residency at the Ohio State University. His pandemic leadership, marked by innovative outbreak management and CDC-recognized COVID practices, cemented his role as a national thought leader in correctional health. Today, we will explore this exciting journey with him, his insights on leadership in high acuity correctional settings, and his thoughts on the evolving demands of clinical excellence in this often overlooked space. Dr. Ladele, Gregory, welcome to this podcast. And then I will turn it over to you to begin our conversation.
Well, thank you.
Okay, well, good. Dr. Ladele, tell us about where you went to medical school and completed your residency, and most importantly, for our purposes, how you came into corrections.
No problem. So, as Susan mentioned, I went to University of Medicine and Dentistry in New Jersey, and I actually, wanted to say I had got exposure in my third year of medical school at Correctional Psychiatric Center. So, back in residency, you kind of were grouped into categories of, I think it was 12 different layouts. And I purposely put myself with the surgery interested medical students because I knew I wanted to do primary care, but I wanted the great rotations. So, and Correctional Psychiatric Hospital in New Jersey is a 600-bed inpatient facility. And they had only one spot. And within the tracks, there was maybe about 12, 15 of us. So it wasn't hard fighting for a psychiatric spot among surgeons. So I got the opportunity to see exactly how incarcerated patients, once they are triaged from the correctional facility to the inpatient state facility. Two things I learned from that experience. One, I had a love for mental health that I didn't know I had before. And knowing that I was going to be a primary care physician, I know that that would be a portion of the care that I would provide. And then also, I love the multidisciplinary approach that I saw in that inpatient psychiatric facility with physical health, mental health providers, and other healthcare professionals. And I think the other thing that I saw was how can I say, they seem to be more relaxed. They seem to have understood life-work balance, which I'm looking for as a Generation X kind of millennial. If you look at, the cusp of where I was in terms of age ranges. So it allowed me to really kind of get a gist of what corrections may offer. Unfortunately, as I went through the rest of my medical training in residency, corrections was deemed as a second class place where you go when you can't go anywhere else. So from Ohio State, I got more exposure with academic medicine and working with the underserved population. And I spent some time working in outpatient in hospital settings until I did a locums in Florida, and I fell in love with corrections. And I haven't looked back. That was 11 years ago. So UMD&J was my start, where I first got a sense of corrections. It was further, how can I say, it was further infused at the Ohio State. And then when I moved to Florida, that's when I let go and was able to see the opportunities that that corrections offers. So those are my experience thus far that I cherish.
Dr. Ladele, looking back at the beginning of your journey into correctional healthcare, what assumptions did you have about working in prisons and jails that proved completely different once you stepped inside?
Well, first, I didn't know the difference between jail and prisons. My experience prior to med school and core experience was Law and Order. All you saw on TV is they went to jail and they may have some services, but you really just didn't get a chance or opportunity unless you're in it. Um, I quickly learned that there is a huge difference between jails and prisons. The one thing that I learned very quickly is I look at jails, if we're going to provide analogies, almost like an ER setting. Individuals are coming from the streets. You don't know if they are intoxicated, if they've had trauma issues at all. And so in many instances, they're coming in and you're assessing pretty quickly to ensure that their healthcare is stabilized and that you're providing earlier interventions if necessary. Um, and then also with jails, when you're looking at community partnerships, for me in jails, one of the most essential partnerships is working on reentry. And then I'm working with the ERs themselves. Just as I mentioned, you look at jails as ERs. And so you want to make sure that when patients are coming in from the streets from being arrested by police officers, that they're medically cleared and that there are no issues that occur that could be exacerbated while they're in the facility. And then also working with reentry programming to make sure that when they're released, which can be hours to almost months or years, that there's a warm handoff to the community. With prisons, I look at them as long-term care facilities. I look at them as skilled nursing facilities as well, in which more of my central partnerships is with oncologists, with academic centers, because individuals here can be incarcerated for a year and a half to life. And so you're seeing more chronic illnesses, you're seeing more typical presentations of diseases that in a community, a lot of times is either an easy fix or they have more access to care, supposedly. But with the prisons and working through that, I found that working with oncologists specifically and other specialists, I'm able to develop relationships for earlier detection as well as earlier prevention. I would say, as an example, one of my contracts that I manage in, I've managed almost 50% of contracts within the United States. Excuse me. In the United States, I think 50% of the states I have had a contract in or have provided correctional health care to some degree. And in one of the states, I saw that there was a significant increase in prevalence of multiple sclerosis. So being able, and I'm comparing it from not only the US, but global prevalence. And so being able to work with the local and regional rheumatologists and other specialists to kind of ensure that we're providing not only state-of-the-art care, but we're actually having accessibility via telemedicine. Bringing those specialists on site allow me to understand the needs for prisons that sometimes you don't have that opportunity with the transient population of the jails. The other thing I would say, and looking at both of these, is that there is a larger compliance rate in jails and prisons that I did not see in the community. HIV, it is very difficult to find statistics in my experience where I don't have compliance or a detectable viral load, because the patients, I think, are so much more involved in their personal ownership of their healthcare delivery. And I see the same thing with diabetes as well. I've seen way more controlled diabetics through total lifestyle changes and compliance to their medical intervention. And I think that's one of the reasons that I still stay close to corrections. But jails and prisons, definitely different. Healthcare delivery is the same, but your population in terms of transient nature is what differs.
Great. So when I first met you, I remember when I first met you, first time I ever met you. So you were the medical director of the Reception and Medical Center in Florida. It's called RMC Florida. And it's essentially a full-scale hospital and medical center, cancer treatment center, surgical center, dialysis center, all of that surrounded by barbed wire. It's a prison. It's where Florida has 100,000 inmates in its prison system, and it's where those patients who need to go to the hospital or need to have surgery, not all of them, but a good chunk of them, that's where they go. And you were the medical director. What a great job. You want to tell us about that a little bit?
Okay, I will say, just as a secret, it was my favorite job I've had thus far. I know I'm a CMO. I loved it. That solidified and cemented the fact that this is where I belong. As you described, it was a mission or a facility that had 10 or 12 different missions. It was also the first place that I could marry my MBA and my medical degree. And that I think was the happy marriage that allowed me to say, yeah, I think this is a good career choice. I did everything from, as you mentioned, I had a 24-hour urgent care. I had the crisis stabilization unit, a transitional care unit for inpatient psych. I had a outpatient specialty clinic that had 30 different specialty clinics throughout the month. Not only did it provide immediate care in terms of an urgent care setting, but it also had a 120-bed hospital that was completely full. I was able to work on my intubation skills. We had patients that were on vents. I had a radiation and oncology and chemotherapy center. We actually made our own chemotherapy on site. I would have never had that opportunity anywhere else in my career thus far, before or after. It also allowed me that it also had an outpatient setting. So I had a work camp. I had one of the 5 reception centers, plus all of the missions I just mentioned. And by the way, they perform surgeries from hernia repair, ophthalmology, ENT. This is kind of unfortunate, but it was a good experience. This is probably the site where I had the most self-injurious behavior patients, where we had patients that had 60 to 70 surgeries and were only 30 or 40 years of age. And so being able to maintain those type of services between the surgical unit, creating a PACU, and also a full-fledged hospital, I think for me was monumental in my career. It was also, what it also did with speaking to my MBA and to my medical degree, there was one graph prior to going into that experience that allowed me to say, I need to gain this experience. The Bureau of Health Statistics or Bureau of Labor Statistics has a graph that shows between 1970 and 2009 that there was a increase of 200% of providers going into the workforce, which is great, right? But if you look at the other side of the fence, the percentage and increase in healthcare administrators rose up to 3,200%.
Wow.
So now, yes. So now I'm walking into an environment that in many instances is operationally driven. And it allowed me to do 2 things. One, to understand how to speak operationally to my counterparts that represents 10 healthcare administrators for every 1 physician that's in the workforce currently. And then also learning how to speak correctionese. So I'm looking at almost like a trifecta of corrections in terms of safety and meeting the needs of the patient, the operational piece, and then the clinical piece. So RMC was where I was able to get my feet wet and have that understanding and to be able to speak those languages fluently to all the people that are involved or the different groups that are involved in that trifecta. And I probably, saying this, I'm in a Greek fraternity, Phi Beta Sigma. So when I did this, those some of the listeners who may be in those Greek fraternities, that was a Delta sign. So I just want to say, I love Delta Sigma Theta Alpha Kappa Alpha, which is my wife's sorority, and of course my sorority, constitutionally bound as Zeta Phi Beta and Sigma Gamma Rho, who I love. So don't want to offend anyone. I just realized when I did that, but have love for all of the Greek sororities in the Divine Nine. But really enjoyed my time with RMC to get back to the topic.
Dr. Ladele,
Yes, ma'am.
was there a moment early in your correctional medicine career and journey, a single patient or a single story or ethical dilemma that shifted your understanding of what this work truly demands from a physician?
Okay. I have probably two stories, time permitting. I definitely will share one. Hopefully, it will share two. One was in my experience. This has happened several times in and out of corrections, but this one in corrections, I had a patient who admitted that they would commit a crime. They knew the judicial system so well that they knew what crime to commit and the sentence that went with it. They had a very rare condition that only one pharmaceutical company in the world made the medication. And unfortunately, this person was not eligible or was not able to get insurance coverage. So this person explained to me that I think I was on their fourth time going in through the system, that they were only able to receive treatment when they came into the correctional facility. The medication was tens of thousands of dollars. And when you walk into a correctional facility, we're responsible for everything from the hair follicle on your head to the longest toenail you grow. And unfortunately, on one of their last days, they endured a very traumatic experience. And I remember the patient saying to me, I can't do this anymore. If I don't come into this facility, I'm going to die from my medical condition. But if I stay here, I don't know if I can endure another traumatic experience like this again. That bothered me. It bothered me that a person was deciding to choose corrections just because of the fact that they couldn't get care on the outside, for whatever reason. And I'm not saying there's a look, a stereotype, but when I looked at this person, nothing gave me corrections. Nothing was rough or tough about this person. And I'm just asking myself, no one decided to call or contact this company to see if they could provide charity care. And as he was getting close to the end of their sentence, I contacted the company and without giving out too much information, said, this person can't come back in. I need for you guys to extend some type of care to this patient. And I can assure you, I don't think we'll see this patient again, and they could be a productive member of society. That was probably 11 years ago. I checked every 6 months to see if that person's name is in the system. It hasn't been. Imagine if that intervention was done earlier and that they had access. Now, I don't want to get too much to the politics of insurance coverage because I can be here all day. But I have found that that is a story, even if it's of a rarity in a sense, one of those stories is too much. And so for me, it made it my business that when we are speaking to our patients, we have to understand the culture that we're in. As I mentioned, I've been in 50 different states, 50% of the United States where I've dealt with correctional healthcare. There's a lot of regional differences. There are a lot of cultural norms that I think as a provider, we are responsible for learning and hearing a story. We're all three of us are healthcare providers. And we hear that old adage of 90% of your diagnosis is history, 10% is examination. And I think if we focus more on that 90%, some of these cases that we'll catch and be able to provide the care that's necessary. I will never forget that case. So that's one. The second one, I would say, was a patient. This was kind of a full circle experience. I've never had chicken pox. I've had the vaccine 4 times. It doesn't stick. If my dad is watching this, he's Nigerian. He believes that Nigerians don't get chickenpox. That is not true. But I'm gonna let him have that. Let him have that. So I've never been able to get chickenpox. There was a patient that had chickenpox, and well, I was told that this patient had chickenpox. And so we admitted him into the hospital. And I sent a colleague of mine to evaluate. I like to have personal ownership and hands-on, even though I have been a clinical leader for 9 or 11 of the 11 years I've been in corrections, I've been a clinical leader, but I still like to be hands-on. So this patient, I said, okay, the patient has chickenpox. It was a Friday. I'm fine. All weekend, I'm thinking about this patient. Okay, what's going on? Is he getting better? Haven't got any phone calls. So the first moment I walked in on Monday, said, okay, how's this patient doing? Doc, he has a temperature of 100 to 405 degrees. So in my mind, this chickenpox is getting worse. I know my wife may be watching, but I put on a hazmat suit as much as I can to prevent myself from getting chickenpox. I walked in, the patient was sick, vulnerable, upset. And I'm looking at this patient and I'm like, this is not chickenpox at all. And I'm like, hey, patient was a little irate, which was understandable. And I said, hey, look, I need to make sure I help you. I don't think this is chickenpox. I think this is something more. I think this is more serious. So I said, what I'm going to do is I have to escalate this to an academic hospital or community hospital because we don't have the resources to manage this. So I called EMS. EMS gets on, comes by and says, we're not taking this patient. This doesn't seem right. I think this patient is completely infectious. We don't know what it is. I said, no problem. I'm gonna call your medical director, who I know. Call the medical director, handed my phone back to them. And this is the joy in working with your community partners. Even though I couldn't hear what the medical director was saying, I knew that the medical director was saying, Dr. Ladele said this patient needs to go, he needs to go. Got several apologies, said thank you, but please get this patient out to the local facility. Patient went out and it was not chickenpox, it was something more serious, something that you typically would treat at a burn unit. I had a doc, and I can mention his name, Dr. Lee in Jacksonville Memorial, did an excellent job of managing this patient. Even though this particular facility doesn't have a burn unit, he managed this patient. And all the other facilities that had burn units didn't want to take the patient. Sometimes correctional patients scare providers because of the litigious environment that we're involved in, which if you're practicing medicine, evidence-based medicine, it shouldn't matter. So patient got better, came back, got better. 5 years later, I was doing a tour of the same facility. And this patient screamed out, Dr. Ladele, mind you, I'm in a group of 20 people. And he's like, do you remember me? Now, mind you, I'm just trying to lay low. I'm 6'6", 275 pounds. It's very hard for me to lay low, but I was trying. And in front of the group and in front of other patients, he said, Doc, I remember you. I remember you saved me. I remember what you did and how you got me from point A to point B. And your hand, and these are literally almost the exact words, your hands extended from where I was at correctional facility to that hospital. And the doctor there and the team there told me that the expectation was that if they didn't treat me right, that it would be a problem. And I got better. And it's because of you that I'm here. I was windmilling those tears and I'm windmilling them back now.
That's
I
nice.
never forgot that. And for me, it's not about the money. It's not about rewards, accolades, or anything else. That's what matters to me.
Good story.
Yeah, and that changed my practice in corrections. I'll never forget it. And
Good.
that will never top any award that I've ever probably will receive. That was my
Yeah.
award.
Good story.
Y'all
So
got
one
me
of the
here windmilling a little bit.
Yeah, that's good. That's a good story. So you served in many leadership roles, and I've had the same position. When you're up in the upper echelons of management, you sometimes the risk is that you lose your connection to clinical medicine. How do you maintain your connection to clinical medicine, being the chief medical officer of a big company?
One, I don't live in the ivory tower. And I think sometimes that is what you expect for someone in an executive role, is that they direct from the ivory tower. I visit facilities. In my years of being a CMO in a 4-year time span, I flew 1.7 million miles on American Airlines. 1.7 million. And it was because it was important for me to be on site, for me to understand the challenges, understand the rate limiting steps, understand who the catalysts are. COVID taught me that a great deal. Um, I internally promoted a lot of people because they were rock stars. They were hiding behind individuals that may have not been the most productive. So for me to have a better understanding of remaining clinical within my administrative role is to be out in the field. Second thing is I am a Q Banks guru. My last board exam was 2022. I still keep my questions on my phone. Um, Not a shameless plug because they don't owe me anything at all, and I'm not endorsed or invested by anyone who I mentioned. It's just my experience. Rosh Review got me through, so I still continue to use those board questions, and they keep me updated of what's going on. And then I perform my rounds. I do what I call drive-bys. When I go to a facility, they will tell you, I will go to the local hospital. I will say, hey, do you know anyone from the facility that I manage? I want to know whether or not there is, bi-directional dialogue. And I will do rounds. If we have a patient that's in the hospital for longer than 10 days, my expectation is that our providers go to that facility. I just did this, I want to say last week or 2 weeks ago. It was a hospital in Southern New Jersey. I'll shout them out because it was a great experience. Our Lady of Lourdes in Camden, New Jersey. We had a patient that was in a hospital with a very serious situation, and we were trying to figure out how do we triage this person to the next level. My team said, okay, we're going to go and have this meeting. I said, I want to go. I'm nearby. I want to go and I want to and have this conversation and meet with the team that's there because we're going to have constant interaction where patients are going to leave our facility and before they come back require some level of rehab. So let's go and help educate on our resources because I think in many instances outside, and I will say this, I was definitely one of these people that were thinking that, oh, in corrections, they don't provide any care. They don't provide good care. And it was to my amazement that when I crossed over to the other side in corrections, the level of resources and the level of acuity that is found there. So being able to have that conversation with, that particular hospital and seeing the movement and the traction is always something that's appreciative. And so that's how I keep my clinical acumen sharp and strong. And I do a lot of presentations at the NCCHC. I do a clinical series called Clinical Pearls, and I create these vignettes. And I think I have one that's like hypertensive urgency. But in that clinical vignette, I'm looking at, okay, what medications are appropriate? What guidelines do we use? Joint National Commission 8. What are secondary issues that come along with hypertensive urgency? Looking at sleep apnea, doing a more comprehensive workup. So those are things that keep me updated with lecturing, continuing learning. We're all lifelong learners as physicians, right? So, it's very easy for us to fall into the trap of being operational with losing things. And the last thing I would tell you, my biggest fear in life is having a loved one, family member who has something simple as a pneumonia and I don't know how to treat it. That is my nightmare. So keeping up to date is important to me in all those facets of my job.
So ambitious, Dr. Ladele, and so very, very much so. You had to inspire not only physicians,
Mhm.
leadership role, but also entire interdisciplinary teams in high pressure settings. So, what leadership practices have you found most effective in retaining compassion, excellence
Hmm.
behind the prison walls?
That's a very loaded question, Susan. I'll say this. Take time to recognize the talents and efforts of your team. One of the things that I've learned very quickly in an interdisciplinary team is that everyone has their job, but you have to be able to figure out if there is a production line and everyone is contributing their particular skill set or talent into developing that product or that service. You have to be able to know what resources each of those individuals need and the impact. I will tell you a very quick lesson I learned is understanding equity versus equality when you're learning the talent and the stakeholders in this team. So one of the things I've learned very quickly is equality is great. I think equality and equity sometimes are used as interchangeable terms. Where equality is, I'm going to give everyone the resource that they need to be successful. However, if you don't take the time to learn your team, you may realize you're giving people resources that they don't need or they can't benefit from. And so I like to approach things from an equitable perspective where I'm learning what everyone needs and I'm giving them what they need to be successful in equitable measures. So that way, one, I get a chance to know who my people are. I get to know their strengths. I don't use the word weaknesses, I'll say areas of opportunities, where that way they can understand the bigger picture. I think also it's great to be intelligent, but emotional in front of intelligence, I think you mentioned earlier, is important. I think being able to develop emotional leaders and for them to understand what that truly means. Um, you know, I don't want to say traditional intelligence, but intelligence outside of emotional is great. But if you look at all of the most revered leaders and you look at the components of emotional intelligence, you'll be able to see between the five which ones they use very well. And then I think the other thing is making sure you praise in public and you criticize in private. The other thing is advocacy out loud. That is important. Making sure that you advocate in front of a group, in front of individuals who sometimes don't feel like they may have a voice to orchestrate what's necessary. And as I mentioned to you earlier, Susan, I found a lot of great emotionally intelligent people that were just hiding behind mm, uh, entities that was holding them back. And so for me, even though COVID was a very trying time, I found success in finding people that were contributing to the betterment of corrections, the betterment of healthcare delivery as a whole. So I think that's how I've been able to manage high pressure teams, is being able to instill in them my expectations, but at the same time instill in them that I want to invest in your success.
Mhm.
So that's one of the reasons.
All right, what are your strategies? What do you personally do as CMO to recruit young physicians right out of training? Do you have a method?
Another good question, but I do this every day. Understand newer generation of providers or in any field, work-life balance is important. I will tell you a quick example. I was just talking to a group of talent acquisition in HR, that I am starting to see more individuals that are coming into the workforce that are taking multiple part-time jobs versus a full-time 40-hour job. And and over the last couple of years, I'm trying to figure out why. Why is that? For my baby boomers, that's hard to understand. For, my generation before that. But what I'm seeing now is work-life balance is important, but I'm also seeing those individuals that are working in a 8-hour or 15-hour job. I am seeing productivity that is 90 to sometimes 120% than what I see in individuals that are working 40 hours a week. They're able to recharge their battery. I get feedback from the team that they're bringing forth just an energy and a motivation to want to do more and to want to educate. So what I see myself promoting more, whether they're part-time or full-time, is making sure I invest in a work-life balance. A lot of my newer providers, they want to travel more. Retirement, they don't want to retire at 62 or 65. They want to retire at 50. When I was at The Ohio State, financial advisor was already in my internship year talking to us about how we want to invest because they understood very early on that younger generations coming in want to enjoy life as much as they can. I would say there's a bad rep with millennials, meaning like um, they require more hand holding. They are spoiled. What I see is they want mentorship. They want frequent feedback. They have the skill sets and the technology to move faster along in their career than probably previous generations. They value skill sets over seniority, which I do. So, one of the things that I do is that when I meet someone and they are a new employee, we set their resume up and I put it on a big screen and I say, here are all the skills you have in a year. I want to sit down with you and I want to be able to figure out what your resume looked like before you got here versus now. So when I do quarterly reviews, when I do biannual reviews, the resume is up and I'm saying, you tell me what you've done, and I'm going to add to what I think you have done and you've taken for granted. And by the end of those meetings, what I've shown them is I've invested or the company has invested in them. And look at how much your resume has expanded. Look at all the skill sets that you've been able to incorporate into your toolbox. And then lastly, look at what you're able to contribute to the industry. And I feel that as an employer, as a leader, if I'm able to build you into that person that you want to become, then why would you not reinvest that back into the organization? I think if more employers knew that, that would be the secret of keeping people. Um, and then also understanding that innovation, newer generations want to know they're on a winning team. They want to know they're doing bigger and better things. I'm now able, in the last couple of years, to attract Harvard and Dartmouth and Ivy League and really good, strong programs or providers of strong programs that corrections probably couldn't get 10 years ago. And then because innovation is not only technology, innovation is also the thought processes and work ethic and developing workflows. And so it's essential that employers, and if you're a true leader, if you understand that where we are in the workforce now, that's what's necessary. And if you're not able to do that, you're not going to keep your employees, past, present, or future. That's my shtick. Simple investment in your people.
Transitioning to correctional medicine and healthcare equity, some terms that we've explored earlier in this conversation. So, Greg, what are the most urgent health disparities among incarcerated populations, and how can systems better address them?
I'm going to be biased, Susan. I'm a primary care physician. I said this earlier. Preventative measures is first and foremost to me. If I can prevent you from having the disease process or exacerbation of the disease, I've done my job. So I'm going to piecemeal my answer to you in a couple of ways. I think one is for my team, and this is for myself as well, to determine the level of preventative care that's necessary for our patients. There are 3 tiers and a questionable fourth in terms of primary prevention. I'll start with primary prevention. Primary prevention aims at preventing disease. And this is for those that are not as familiar. I know the 3 of us are familiar, but I find it's not used as often. So primary prevention, aims to prevent diseases and illnesses before they occur. So in my juvenile population, it completely essential to make sure that we're looking at vaccinations. We're talking about tobacco cessation. I've been very perplexed, and this goes back to our conversation before. The level of acuity, when I think about my community experience or our patient experience and then coming into the jails, I have been very astonished at the level of primary care or primary preventive care that hasn't happened in our juvenile population in terms of vaccinations in the catch-up phase. And some of it's because they didn't have an opportunity because their loved ones didn't provide that. And then also, I think sometimes after their toddler stage, things just gets missed. So, aiming to prevent disease in that population, getting a hold of them before different agents and risk factors become a disease process or illness is important. Unfortunately, outside of my juveniles, primary prevention has already surpassed in my population, my adult population corrections. So secondary prevention is where I see most in physical health, is focusing on detecting diseases in asymptomatic patients and providing treatment earlier. So this is where, again, if we're looking at smoking cessation for my teenagers who are just starting it and don't really understand the risk with lung cancer, now I have patients that have been in the prison system for 40, 50 years or have been smoking for 30 years. And now I'm trying to make sure that they don't succumb to lung cancer or complication of lung cancer. So low dose CT scans, as an example, provide a secondary prevention, or our pap smears and things of that nature where there's a slow growing process for that disease, but being able to have specific screenings and serial checkups. Tertiary prevention in terms of healthcare disparities. Unfortunately, I didn't learn this really till I got to corrections. My mental health and my dentistry a lot of times don't have the luxury of primary and secondary prevention because the patients have already got to the point that the disease process is there and it's flaring up. And now you're trying to minimize the exacerbation or slow down the progression of the disease process. So it's my dentists that have taught me the act of tertiary prevention, where in many instances, this patient who has cardiac disease has poor detention and hygiene. And now we have, and so an example of tertiary prevention is tooth extraction, or my patients who are have issues with cancer, who now are going the radiation route, have to have all their teeth removed if there's concerns with infection. So that's kind of where the healthcare disparities for me are concerning in teaching primary, secondary, and tertiary intervention and where it is intercepted in the healthcare. And then quaternary is kind of a newer prevention. And that's where you're looking at how medical interventions can cause more harm than health. That's probably one of the hardest ones to teach, and also the hardest ones to articulate to your patients. You see that with prostate cancer, where okay, you have a PSA that is slowly growing, but there is a concern of prostate cancer, and having the ability to teach my providers and also articulate to my patients that watchful waiting and surveillance is an option. And that sometimes, depending upon the interest of the patient, sometimes there could be more, there could be side effects or some harm to providing medical intervention, depending upon where you are in the process. So I want to make sure, as a disclaimer, I'm not saying that we don't treat prostate cancer, but the fact that you want to give the patient the ability to make their decisions with all the information that's available. With this healthcare disparities as well, that we had a pandemic, but we also had an infodemic. In which there was miscues in communication. And even though the pandemic was an example of that, I still saw that before the pandemic. And so it's also important in healthcare disparities to make sure that you are enhancing relationship with community partners. We talked about that with substance use disorders and working with reentry programming, which is a very hot topic in corrections. And I think working with a lot of grants or organizations that are key and kind of working in that area, waiver 1115A. I don't want to get too much into that, but something we're looking at and providing healthcare coverage for individuals that are within corrections is one of the things that I think we're working with. And then again, always being able to invest in innovation and bringing more on site. And I probably will talk about more innovation later on in the podcast. But for your question, preventive care measures will definitely do a great job at placing a huge wedge in the healthcare disparities we see in our populations. As a primary care provider, that's what my bias is in terms of the target goal.
But how does, when you consider ethics and logistics too, but well, let's focus on ethics. How does practicing in correctional medicine differ from traditional clinical practice?
Jeff, you're going to get me in trouble. Susan, too, is your accomplice. One of the biggest hurdles for individuals that are transitioning from the community to corrections is in the community, and I'll speak for myself because I had a hard time with this, is that in the community, I was a revenue generator. I knew how to aggressively build necessary for the organization. I was, and just showing you my age, I knew my ICD-9 codes in and out. I knew my modifiers. I knew how to, with integrity, I knew how to code to stay afloat and to bill appropriately. Got into corrections. Yeah, I may use ICD-10 codes, but I'm no longer a revenue generator. I now am a cost saver or I'm an expense, depending upon who you ask. And so I have this triple A theory of when you're coming into corrections and you're making that transition from being a revenue generator for a practice to being a cost containment, a cost saver, the triple A is you sometimes have to make the adjustment of autonomy, accountability, and authority. Because a revenue generator allows some of those A's to be higher in outpatient practice or in the community than it does within corrections. I still believe that if you're going to be a well-balanced leader or clinician, having the ability to make decisions, which is authority, we already have the accountability as a provider in general to make sure that patients get the care they need and the autonomy and the freedom to make those decisions. That is really when I'm dealing with a provider that's coming in, I hone in on that because usually if a person is going to leave a corrections, it's either they had poor onboarding, you know, the old adage of people don't leave organizations, they leave a boss. And the fact, so you shake your head, and the fact that they don't feel that their authority, accountability, autonomy match. I think also it's navigating through the safety, the custody part medicine. As I mentioned, I'm 6'6", 280 on a good day. I've never seen a physical altercation a day in my life in the times I've walked in any of the facilities that I've worked in or have managed. But I understand the importance of the safety. And with that being said, I think, again, going back out and ensuring providers, I mean, I've had providers who said, I will not see anyone in orange. And I'm like, so when they change their outfit and they go from corrections to community, you'll see them then? Yes. I'm saying, well, what's the difference? This patient still needs the care that's necessary. And sometimes you're the only one in that rural area that can provide it. Or we're willing to go across state lines to get the care that's necessary. So being able to provide that navigation of safety and medicine to our community partners is important. And then also being able to indicate to providers that even though you're used to an open system in a community and now you're in a closed system, you have the best of both worlds. You have the ability to have a captive audience as your patients. They are way more compliant. And I will say this till my obituary is printed. I have never have had as much gratefulness, gratitude with my incarcerated patients that I had in the community. Especially if you're giving them, listening to them, and you're giving them sound advice, and you are investing in understanding who they are and the culture that you're in. And once you get that, I don't care if it's a riot. I've never had concerns if there was a concern of a riot. And I've had patients come up to me and say, we might riot in about a month or so. Doc, you're cool. You can walk around. And I appreciate that. Now, again, I'm always wanting to be safe, but knowing that my patients within the walls understand that regardless if they were out the walls, again, my hand extends beyond that. You're my patient, whether you are here or whether you're outside. And that is what I expect. And I'm non-negotiable with my providers. And as long as you have those ethical, understand the logistics behind it, I think you're going to become a sharper provider if you come into corrections from the community. I know I have. That's been my story.
Good.
Dr. Ladele, how can chief medical officers influence state and national correctional health policy to become more evidence-based?
Okay. Again, I'm going to go back to some of the same themes. Leave the ivory tower. Before you can demand or to influence national policy or state policy, understand what your vision is and be able to articulate that to the group. I have been in several meetings, several caucuses where I'm listening to a clinical leader or a leader in general strive to make mandates and navigate through the political turbulent waves. But in my mind, I have a hard time gathering what their vision is in this. It's great to have an ultimate goal. It's great to check a box. But you have to be able to sit back and think about what is my vision and my mission, and how do I want to carry that out? Then develop a process of where I want to go. I think also understanding that in this role, you're a cultural cultivator. And again, I've said several times within this podcast that it is at your advantage to understand the differences, the regional differences of the patient population that you're treating. Again, at one point, I had 18 to 21 states. I will share with you, and I can say this, I managed a contract in Wyoming. I'll never forget them telling me, we're the second most rural state to Alaska. We kind of do our own thing. And, you can try to push, policy on me if you want, but it has to make sense. And so, again, I had to redirect what my vision was, and we got to where we needed to be. But it was my homework assignment to have a good understanding of what they needed. And I don't want to use the word love language, but I want to understand what their communication language was to be able to deliver the message that's necessary. And then also becoming fluent in correctionese. No matter how much Theodore Roosevelt said it very poetically. People don't care how much you know till they know how much you care. And if that is not evident in your messaging, all of it goes over the people's heads. So being able to understand that we are the experts, we are the channel, the vehicle to provide the message, but we have to be able to provide that and kind of what we do and be an example of that.
Right. Well, that's great. That was a great answer. And of course, Wyoming is right next to where I live. So
I learned very quickly.
yes, exactly.
Good times in Wyoming.
How do you approach care coordination? You talked about warm handoffs at the end, especially at the end. That's the hardest one from my perspective. It's easier to do coordinate care and continuity of care at the beginning, although there's problems there too. But how do you especially coordinate continuity of care at the end when patients are transitioning back to the community?
So kind of one of my processes I've kind of developed over years is I have a hybrid system of the Socratic method of asking a lot of questions, understand thought process, and my processes in developing and minimizing any gaps of kind of continuity of care. But also I have a introduction, production, and construction theory as well. And so in any process that I have, the introduction phase is for me to learn. It's a finite phase, but it's for me to learn exactly all the challenges, all the rate limit steps that are involved in making sure that these processes from intake to release are made aware of. Again, Susan, I know, Jeff, you asked me the question, but Susan goes back to one of the questions you asked me before of, how do I manage the stakeholders and moving forward in the process of my administrative responsibilities and my clinical responsibilities. So being able to understand who my rock stars are again, and this process, I am the very nicest person. Everyone loves me because I'm trying to figure out what your knowledge base is, what your thought processes are, and then what are the problems of the continuity of care from intake to release to the community are the problems. Because most of the time in that situation, they know the problem, they know the solution. So being able to kind of draw up all of that is my introduction phase into this process. Production is next. This is where I'm not as well liked. Because this is where I come in, and now I have gotten all the information in my research development stage of my introduction. Now I want to be able to put all the people in the right places, develop the equitable resources that individuals need to move forward, and then minimize those rate limiting steps and promote the catalysts that are involved in that process. Again, this starts from any process, from intake all the way to the patient now is 1 month out of release. And then the last part is construction phase out of my introduction, production, construction. Now I have the right team. Everyone knows their roles. No one is concerned about pulling the other person's weight because everyone knows how their role impacts the process, whether it's mental health, whether it's IT, whether it's operations, whether it's nursing, whether it's the discharge plan, whether it's custody. Everyone at this point knows what they need to do, and all the talents are accounted for. Taking that approach allows us to be able to build SOPs and allows us to have credible resources that when I go into the community, individuals understand exactly what our expectations are. And unfortunately, if patients kind of come back through the door of corrections, they understand, again, what the process is for them to start their entry back into the community if it's afforded. So introduction, production, construction phase with a little bit of Socratic approach, I think has allowed me to minimize those rate limiting steps in increasing productivity from the time of patients coming in to the facility and going out. And that is a circumferential process.
Transitioning to innovation, integration, and technology. Very excited to ask these questions here. So, Greg, how do you see artificial intelligence and analytics transforming the field of correctional medicine over the next decade?
Okay. I will say this. I think corrections, sometimes we are a little bit behind in terms of utilizing data analytics and predictive analysis. I think because of my being a younger leader and having to prove myself to more seasoned leaders, I've had to use predictive analysis, data analytics, and AI to accommodate for lack of accessibility for patients. As I mentioned earlier, I've had some providers even put in writing, I will not see your patients, even though I know I'm the only one. Some specialists wise they can manage this. So I have been more innovative and creative. I think data analytics drives how you allocate resources. Again, that's where I believe that the hybrid of being a clinician and having an MBA kind of harmoniously helps out. I think one, having a more academic environment within corrections is important. I think also being able to make sure that you understand the questions that are necessary to develop the data that you need to allocate resources. I'll give you an example. And I had 2 contracts where the ER rate for chest pain was like almost 40%. And I'm trying to figure out what is the issue. I'm a CMO. I'm like, where's this offsite utilization coming from? Custody is saying, hey, doc, what's going on? We're having all these patients go out, and we already know that there's a staffing shortage for custody office throughout the United States. So one of the things that predictive analysis or analytics did for me was I then met with my medical informatics team, my utilization management team, and said, okay, let's put our heads together. One, I want to be able to figure out, is the situation the same before I provide a resource? Remember, equitable and equality resources. One of my sites, 60 to 70% of the ER runs that were related to chest pain were admissions. So I knew right then and there, I need to bring cardiology on. And I gathered up my data metrics, and I was able to meet with cardiologists and work with my team to bring cardiology on site. And then we started to see more preventative care, again, overarching philosophies and things that I'm trying to ensure that is permeated through this podcast. And we were able to see less ER runs and more preventative care for patients in that contract. Flip side, the other contract, it was 9 to 11% of those ER runs were related to cardiac and or inpatient care. So or was related. So my point there was more education. There were more, I call them chat and chews, lunch and learns, that we're going to have working lunch and we're going to talk about different ways, and we're going to focus more on differential diagnosis and what that means and not having tunnel vision. Every 23-year-old that has chest pain might not necessarily have cardiac issues. It could be Taco Tuesday. It could be pneumonia. There's a lot of things that it could be. So the data analytics allowed me to figure out how to allocate those resources. And in both settings, the ER runs related to chest pain actually went down because we were able to figure out what resources they needed to provide more earlier detection and earlier intervention.
Have you any recent innovations in telemedicine or mobile health or any of that caught your eye about really improving medical care in corrections?
Yes, there's a couple that I've been able to work with that I found to be very advantageous in helping. And again, no one has given me any money or investment. So I want to make sure I make that disclaimer that any group I mention or resource is just because I've had great outcomes with them. There is a group that uses AI for physical therapy. Physical therapy, low musculoskeletal injuries, I find to be very associated in our realm of correctional healthcare. I had to bone up a great deal when I went from community to corrections on my musculoskeletal medicine, because just what you see. But there's one group called CareSpace that actually uses technology that looks at range of motion through kind of a tablet that allows you to kind of, with physical therapy, with, again, for me, low skeletal injuries, to determine the rate of success with the treatment plan, or being able to utilize that data to then go back to ortho and say, this is not getting better. We've tried physical therapy, and here are your roadmaps of the range of motion that demonstrates the fact that this patient has pursued physical therapy and it hasn't worked. There's a couple others, Tableau, which is utilizing dialysis from the home or outpatient setting, where you are able to use this machine. It looks like the size of a home printer, where you can actually provide dialysis, traditionally 3 times a week. It could be in smaller durations at 5 times a week. And so now you're minimizing not only offsite care for dialysis, but what you're also seeing with that unit is the fact that with shorter durations, you have less of an issue with fatigue, and they're actually able to do more throughout the day. And then the concern I always have is that when you're doing something from home, especially with dialysis, how great is the concern about infection. And those rates have pretty much been the same as within the community. Picasso MD. I tried to conjure up that someone stole my idea, but I'm glad that someone was able to market it. But I think because of the shortage of providers or specialists, being able to do a curbside consult and being able to contact someone, nowadays we use up to date, and the provider comes back and says, with up to date, they say this. Even so, what Picasso MD does is that it allows you to speak to a specialist, and that way to have a curbside consult with someone that's in that field that allows you, for my preference, is to help you not only minimize a off-site visit, but also to make sure that you've optimized the care on site, that when they do go out, you have all the appropriate labs, and you're not wasting that first visit on just history alone. And then risk monitoring. There's several companies that have the risk monitoring that are helping with patients, specifically in jails, that are able to detect, heart rate and detect other things. I think they've started to become very innovative with the technology that's there. And a lot of times when you are short-staffed, or you have a patient that's come in and they haven't necessarily exhibited any symptoms yet from substance abuse disorder, but you don't have that monitor on, and then having a centralized data center that nursing can look at to be able to determine whether or not this person is having earlier signs of a decrease in their vital signs is essential. So there are a lot of things that I'm starting to see, and invest in that I think would allow us to have better outcomes. And again, Susan and Jeff, to help me with preventative measures.
So we're going to go explore the human side of correctional medicine. So Greg,
Mm-hmm.
what inspires you the most about working in the field of correctional healthcare?
I know I've kind of covered this in some other questions, but I have to say, seeing a light bulb turn on, that figurative illumination when you are talking to a patient, talking to a provider, and you see that they get it, and then they can explain it back to you. That's the chef's kiss for me. That again, that tells me that regardless of the times that it took for that person to get it, they got it, and now they feel more empowered. They feel like they were able to articulate what their concerns were, and I was able to answer. So um, I think working with good people who are fighting the good fight. I will tell you, I've had experiences. Not only, I'll say this: my current executive committee team at CFG, working with them and being able to be a CMO who has all the things I just mentioned to you, to be able to implement those things and to have the ability of autonomy, accountability, and authority to make those decisions is important for me. So working with good people that allows me to feel that my mission of what I want to be and who I want to become is aligned to the company is important. I think working with clients, there are a couple of clients that I've worked with that have been very progressive. I worked with one client, I won't mention their name, but had a very progressive approach to how working with hospitals, especially now with all the funding that is affecting hospitals' inability to stay afloat, being able to create a locked unit and having that mission and that vision and then see it clearly and to kind of work in that realm to develop that is important to me. I had a client or had a mentor. I could actually mention her name because she's retired, Dr. Balcom in Maryland, who taught me about not being the doc in the box theory and the importance of working with the community and being resilient and resistant to not having the care that should be identified for your patient. I had a client also, won't mention their name because they're not retired, but who during COVID allowed me to be the SME in um, developing a process where the local health department could see that though the earlier projections for COVID and corrections said that 66% of all incarcerated patients will become infected with COVID, that was not the case. And that being able to be the liaison between custody and the health department and engaging in a partnership that allowed for them to see what resources we had, I think allowed me to have a relationship and talking about best practices with CDC. Again, my goal in medicine was just to be a medical director of a little old practice. And so to see what that dream was or that aspiration was, and now to be a CMO of a national a company that can provide care for thousands of people would have never imagined it. And so those are things. One other thing I would say is, um, as a provider going into a clinical operational position to now CMO, there's one other person and they know who they are that allowed me to understand utilization management and the business of healthcare delivery. Yeah, I have an MBA, but it's great to be able to have individuals who kind of invest in you and let you know what's going on. And then when you're in left field, they can pull you out. And there was one particular person who has made me a guru with utilization management and what that means. And that's so important in our environment because a lot of times our patients get out into the world. And again, those outside entities don't know exactly what we can do. So having that, very appreciative again. working with good people, that light bulb, those are things that have kept me and inspired me to stay in corrections.
I'm going to ask a follow-up question in this topic we're speaking of.
Mm-hmm.
And that is, Greg, in the leadership role that you are in,
Mm-hmm.
staff wellness and burnout, physician burnout, is such a very important and situation and an area that we need to spend time cultivating and nurturing our staff and people that we work with. So my question for you is, how do you support staff wellness and prevent physician burnout in such an emotionally demanding environment as the correctional setting?
One, and then again, I'll say it as an overarching theme. I have several things in this podcast I wanted to make sure I got out was, again, take the time to get to know your team. As a leader, your team knows your strengths and knows your weaknesses, and vice versa. And when you take the time to invest in your team, they will make sure that your weaknesses or areas of opportunity, so I don't like the word weakness, but I said it, your areas of opportunity to grow is something that could be more internal. Advocate out loud. I've learned that when your staff knows that even when they're not at the table and you are, and they know that there is representation there. One of the things that I take pride in, and this is probably a term I'm using, it's not a medical term, I got street cred, meaning I've been inside the facility, I've been outside the facility. So I didn't forget what it was like being a site medical director. I didn't forget when I ran a 66-bed infirmary in Arizona. I didn't forget what it was like being an RMC. So now that I'm executive, I have to be able to vocalize on both sides of the fence of when right is right and wrong is wrong. I'm a proponent of integrity. I'm never going to ask anyone to do what I would do for myself. Again, I said I'm tall. I didn't tell you my age, but I can't play football, basketball at this age now. I can't, afford to run the runway and be a model. This medicine thing has to work. And so, with that being said, having the team and investing in them is important. And the other thing, your team should not only see you when there's a crisis. So if you only are seen when there's an issue, guess what's going to happen? You're going to be associated when there's an issue. And you're not going to get the transparency. You're not going to get them to be forthcoming. You're not going to get them to lay their head down because they're not sure what's going to happen next. So I do tours regardless. I might happen to be at a family reunion. And I said, you know what? I got a contract, an hour or two away. Let me stop by and see how they're doing. Let's break bread and have a lunch and learn and just talk about what's going on. I think and then also it's okay to show empathy. I think in many instances, some of my previous leaders were like, you can't show empathy. For what? I'm human and so are they. So if I show that I'm not human, then I'm never going to get that out of them. When there's a holiday, a wedding, an anniversary, a child's graduation, I don't care if it's pre-K, and they tell you that, I make sure I say, how was that pre-K graduation? Or how was the fact that you got this award? Tell me about it. Because it took me until the last 5 or 6 years to realize, and this is coming from a younger generation than myself teaching me this. You spend a lot of time at work. Mm-hmm. Why can't you have fun at work? Why can't you develop friendships at work? Professional friendships, of course, but why can't there be? And I will tell you, my generation Z, my generation Alpha, when I mentor, and my millennials are like, if I want to spend a lot of time here and have work-life balance, I want to feel like I'm not coming to work and I hating it. My baby boomers didn't care. They're like, I'm working, I'm okay, pay me, and I'll be fine. And Generation X, we're kind of, in between. We're kind of nudged in between those two generations. So that became important to me, that it's okay for me to develop a professional friendship and to be engaged in other things that people are doing that interest them. And then listen for concern and do not hesitate to ask. is anything else going on? Like I talk, and here's the funny thing, you're not going to believe me. Jeff probably wouldn't believe me on this as soon as I know we're just meeting for the first, for the first couple of times. Um, I'm actually introverted. I'm only extroverted at work. And I know people don't believe me at times, but because I talk to so many people in different regions, different accents, different cultures, when you are talking to your staff, I can hear a difference in tone, cadence. If something's going wrong. And sometimes people are like, well, no, I'm fine. I'm like, let's stop. Time out. Time out. No, your voice is different. And let me tell you why I hear the difference. And sometimes that moment of just giving that person a chance to vent or to say, you know what, I was having a moment. I'm good now. We can continue on. People don't forget it. I know I don't. A person who has the emotional intelligence to say, I think something is bothering you, and I can't move another further until I figure it out. I never forget those experiences. And then in my mind, I'm saying they're not only engaged in me as an employee, they're engaged in me as a resource of being someone who matters. So that's kind of how I support wellness. It's important.
Good. All right, let's talk about ACCP and the organizations, the professional organizations, NCCHC, ACA, and community stakeholders, all the external organizations. What tips do you have about interacting with all of them?
I think it's engaging in forums like this. Like I just mentioned to you, um, when you are in an executive position, and probably people don't like saying it, but it's the truth. It's a truth of many. You get very concerned of where your voice, where your picture, where your image of who you are is at. And you're very hesitant because you're so concerned about cancel culture. And so what I found myself over the last couple of years in doing is um, focusing on arenas. And here's the thing, it's not just in corrections, it's being able to take corrections to other arenas. I'll give you an example. I have an upcoming meeting with a group from Business Today, and they're representatives from this nonprofit organization. It's one of the largest student nonprofit organizations in the United States. And I think it was formed by Steve Forbes in 1968. And they reached out to me and said, okay, hey, look, we want to know more about corrections and the impact that it has. And I'm going to take that opportunity. Again, it hasn't happened yet, but I'm going to take that opportunity to say, here are all of the things that a correctional environment offers. Clearly, because we're in healthcare administration in terms of providing healthcare delivery and corrections, we're part of the 3,200% of healthcare administrators that enjoy the workforce. So there are opportunities, and even with providers, with nursing, I have been able to go to different hospitals and other forums to talk about ACCP. I was just in a meeting with someone, and it was with a consent decree, and it was a subject matter expert. And I'm like, why don't you join ACCP? You have a collegial environment there that will help shape and mold what you're doing. And also, if there are other consent decrees like yours, here's a group of people that understand it. That's one of the things that I want to do as I get more seasoned in age and within corrections. I'm not leaving corrections. This is probably where my career is going to be, but being able to, an example, to promote what amenities that corrections offers is important. But I think also is to be able to be a living witness of what you are promoting is important in those environments. And so I expect, Jeff, for us to see a huge increase in ACCP and NCCHC because I think we are a hidden gem within corrections and corrections in itself. And I think some of the newer generations now are looking for more, I don't want to use the word unconventional because I think that's unfair to us, but are looking for other opportunities outside of your traditional setting of outpatient and inpatient setting. And so that's where, so I I ask that individuals that are in ACCP, is NCCC, or in any correctional environment, that when you are out and about, that you promote what we do and demonstrate the resources and the skill sets that we have. Before corrections, I thought to be a sharp provider. I think I'm way sharper now just because of the pathology and because of things like this. I would have never did a podcast. I've done one besides this one, but I was very hesitant in doing it. But I'm feeling myself doing this more and again, carrying a banner of what we do and the fact that a lot of us are here by choice and not circumstance. I can hang my shingle up anywhere, whether it's outside the hospital or next to a correctional facility, and that needs to be further promoted.
Greg, what do you hope your professional legacy will be as a correctional medicine physician and a leader in correctional healthcare?
Simple. That I've always had integrity. I want to be able to, I want to have people see that I pushed the envelope. Um, I was not okay with status quo when status quo was the prevailing um, theme, and that I brought in, or at least tried to attract high quality professionals into this environment, and in this, hmm, that in this sector of medicine, that I was able to assist in serving what people sometimes call the undeserving, underserved population, and that they were treated the same, or in some instances, even better than when they were in a community. I want to be able to have people provide testimonies that when I went to jail, even though I was going through a rehabilitation setting, that my experience healthcare wise allowed me to leave that system healthier and more aware of my own personal health than when I came in. That's it for me. All my other answers were long. That one is simple. Integrity, and that I was able to attract more high quality professionals and treating the underserved population that we see in incarcerated settings.
This is wonderful. Jeff, is there anything else that you would like to add to our podcast interview today with Greg?
I just want to thank Greg for coming and tell Greg that he's someone ever since I first met him at RMC, someone I admire and I have learned a lot from. Matter of fact, I took some notes about what you said today. That's a good point. I wrote them down.
Well, I appreciate
Just one of my heroes in correctional medicine. So thank you for being here.
I appreciate the kind words, and I appreciate a podcast like this that allows me to, again, demonstrate that there are people that really want to do well and really want to see growth in corrections and want to see our patients thrive more than when they came in with healthcare. So, again, appreciate the opportunity to vocalize that.
Greg, it has been a true honor to have you with us today. Your unwavering commitment to advancing healthcare for the incarcerated population through both visionary leadership and hands-on clinical excellence embodies the very heart of correctional medicine. From your early days in primary care to your transformative roles in statewide correctional systems, your journey reflects a rare fusion of compassion, strategic foresight, and an unrelenting belief that every life deserves dignity in care. Your insights today have reminded all of us that correctional healthcare is not just a practice. It is a calling rooted in justice, service, and human resilience. On behalf of the American College of Correctional Physicians and our audience, we offer our deepest gratitude for your service, your wisdom, and your continued leadership in our field. Your work has helped elevate the standards of care across entire systems, and we are so proud to count you among the most dedicated voices in correctional medicine. To our listeners, thank you so much for joining us. We invite you to stay connected as we continue these exciting conversations with the exceptional professionals who are reshaping the landscape of healthcare in the correctional setting. Until next time, stay informed, stay inspired, and thank you for tuning in. And we will see you soon.
Have a good one. Thanks, guys.
Yeah, that was really good, Greg. You did a great job. Well done.